Hello everyone, and welcome to the weekly Mind Bleep, the surgical series. Thank you very much for joining, and today we're going to talk about gastric reflux disease and upper GI system cancer. Based on your feedback, we're going to try something different today. As the majority of you are saying that you'd like to make the sessions more interactive. So today we're going to use a platform called Mentimeter for you to be able to answer the questions, and then for you to post questions after the end, after I finish the session. So if I could ask everyone, there's going to be a Q&A on this platform later. Please don't post them on the Facebook chat. Please post them here. But I will have a look at the Facebook chat later as well, just in case. So let's start. So just quickly touching on the general format, we're going to go through the clerking of the patients who present with upper GI symptoms. I'll briefly talk about anatomy and pathology, the etiology and the disease process, and then we'll touch on investigations, initial management, which is necessary for you as a junior doctor to know about, some complications, and we'll do questions throughout the session. So the key learning points be for you to understand the relevant anatomy, identify common presentations, which you will likely come across when you work in a hospital. So that's going to be very beneficial for you. I'd like to understand the risk factors for gastric reflux disease and upper GI cancer, and then we'll practice application of skills you've learned during a case. So just quickly, bit about me. My name is Sara Jasionowska. I'm an academic FY2 doctor, and I'm interested in plastics, vascular surgery, and research and teaching. So let's start with a case. For the purpose of this presentation, similar to our previous sessions, you are the surgical FY1 doctor on take when the patient comes through the door. So just keep this in mind throughout the session. So our first patient is, his name is John. He's a 68-year-old male. He's obese, and he has a very significant smoking history of 30-pack years. He presents to you with a burning chest pain, which he has had for 14 days, odynophagia, which essentially means pain on swallowing, vomiting, that again, he's had for 7 days, and some nocturnal cough. So he has been coughing at night, vomiting, has pain on swallowing, and has burning chest pain. Okay. So our approach to the case, we're going to take the history, we're going to examine the patient, and we're going to do some investigations. But first of all, I'd like to ask you a question. So if you could go to menti.com, so it's www.menti.com, and use the code that you can see on the top of the screen. So it's 9447097 to log onto the platform. I'll give you a bit of time, but when you do log in, please, if you could answer the question so I can see that you've logged on. If you could answer the question and tell me what are the differential diagnoses in this case. So again, the website is www.menti, that's MENTI.com. I'll give you a couple of minutes to log in and let me check if there are no issues. Right. Let me post it here as well. All right. Perfect. All right, so I'll give you a few more minutes to do your voting. And they don't have to be gastrointestinal issues. So think about when the patient is presenting with vomiting, burning chest pain, and nocturnal cough, what else could be going on? Because this kind of highlights that even though this is a session on upper GI problems, in real life, the patient may present with loads of different pathologies. All right, hopefully more and more people will be able to log in, and we're going to use the same code throughout the session to answer all the questions, so please don't log out. Okay. Perfect. So looking at your answers, there are a few pathologies that seem to be very common answers. So gastroesophageal reflux disease seems to be very common. Esophagitis, that's very good. Malignancy, gastric reflux, these are all very good answers. Adenocarcinoma, it's very good. And I'm really glad that you have highlighted it could be a heart attack. So the patient could be having a heart problem, which is a very important differential. And you have mentioned ulcers as well, and pancreatitis. So these are all very good differentials for retrosternal burning chest pain. So thank you very much for taking part, and please stay on Menti for later. But I'm just going to move on and touch briefly on the differentials. So the key differentials in here for the burning retrosternal chest pain will indeed be gastrointestinal reflux disease. It could be malignancy, especially that the patient has some pain on swallowing, which is new. So that could be esophageal or gastric cancer. It could be peptic ulceration, as you rightly did say. The patient could be having esophageal motility disorders, which we're going to investigate for as well. I will discuss potential investigations later. But then very important differentials, and I'm really glad that you have mentioned that, are diseases that are not affecting the upper gastrointestinal tract. So cardiac disease, very important differential, because the patient, we don't want to miss a heart attack in a patient that might have a reflux on top of that, or the pain is just very similar to reflux. And biliary disease, so biliary colic, the intermittent episodes of biliary colic can be very similar to flare-ups of gastrointestinal reflux disease. All right, so the next question for you is what symptoms are seen in upper gastrointestinal disorders? So I have given you a few symptoms that the patient has presented with, and just as a recap, patient had retrosternal burning chest pain, vomiting, and I'd like you to think about what other symptoms are seen in upper gastrointestinal disorders. So again, if you go to menti.com, and the code is the same, and just if you could think of any other symptoms. Perfect, I'll give you a few minutes. Perfect. And the reason why this is important is because when the patient presents with one of the symptoms of the upper gastrointestinal problem, then it's very important for you to ask all the other questions, just to be able to diagnose your patient more precisely and choose your investigations appropriately. So rightly so, other upper GI symptoms will include dysphagia. And that is, as I will touch on later, is a red flag symptom. So if a patient presents with a new inability to swallow or difficulty in swallowing, that is a very worrying symptom. But some of the other symptoms we have mentioned, abdominal pain is a very common presentation in upper GI problems. Dyspepsia, so this feeling of indigestion. Pain and symptoms which are worse after eating, these are all very good answers. So you have, I think you have listed almost all of them, but I'll just try to go briefly through the upper GI symptoms that we're going to ask about. All right, So some of the symptoms, you did mention dysphagia, so difficulty in swallowing, odynophagia, that's pain on swallowing, hematemesis, so when the patients are bringing up blood through their mouth, vomiting, ulcers, so the indigestion will be the symptom of peptic ulcers. Also, the patients with upper GI symptoms might have jaundice, so they might have the yellowing of the sclera and of their skin. It's really important in this patient to also ask about systemic problems, because those could point you towards an underlying problem such as malignancy. So it's really important to ask about any weight loss, anorexia, nausea, fatigue, fever, and confusion. As the patient is presenting with retrosternal burning chest pain, we're going to try to quantify the pain. So we're going to use the Socrates approach to the pain, which is essentially used in any history taking when the patient is presenting with pain. We're going to ask about patients' past medical history and past surgical history. And in the family history, it's really important to ask about malignancy, as some cancers, the risk of the patient having a cancer is going to be increased if there is a family history of cancer. And important for the upper GI disorders, we're also going to ask about a smoking history, patient's alcohol intake, diet, and exercise tolerance. All right, so going back to our patient, John, who's 68 years old, he's a male, and he works as a banker. He tells us that, as I did mention, he has a very significant smoking history of 30 pack years. He drinks 3 whiskeys a day, and he is obese. This chest pain that he has told you about has been going on for 2 weeks, and he does have some acid taste in his mouth. The pain is worse when he's lying down, and it's worse after he's eaten. And as previously mentioned, he's been vomiting for 7 days and has had this cough at night for 7 days. He's never had anything like this in the past. And his past medical history includes type 2 diabetes, hypertension, high cholesterol, gout, Helicobacter pylori infection, and peptic ulcers. Very importantly, the symptoms on my right-hand side of the screen, the patient does not experience. So those are the symptoms that we call red flags. So in any patient presenting with upper GI problems, it's really important to ask those questions, because those could mean that the patient might have underlying cancer. So the way we manage the patient, the way we investigate the patient might have to be very different, and there's going to be, we might need some urgent investigations if that's the case. So in this case, the red flag symptoms would be weight loss, dysphagia, so new inability to swallow, or odynophagia, pain on swallowing, voice hoarseness, early satiety, malaise or loss of appetite, hematemesis, or fatigue. So John doesn't have any of those. So we are pleased to hear that. And we're now going to move on to the examination. So we're going to use the A to E approach. We're going to perform the abdominal examination to look for any masses that are palpable. We're going to look for abdominal distension, for any palpable organs. So in particular for organomegaly. We're going to feel for peripheral lymphadenopathy. So we're going to feel, so for the upper GI cancers in particular, we'd like to feel in the supraclavicular fossa. In particular, lymph nodes that are enlarged in the left supraclavicular fossa could be in keeping with a metastatic gastric cancer, which I will go back to later. When we examine the patient, we also look for signs of anemia, such as conjunctival pallor and chylonychia, or angular stomatitis. To complete the abdominal examination, we should do a digital rectal exam and check external hernia orifices. All right, so on examination, John is hemodynamically stable. He doesn't have a fever. His observations are all normal. His abdomen is soft on palpation. There are no masses, but he's tender in the epigastric region. There's no guarding, and the patient declined the PR exam because he thought that there is no indication for it. All right. So what investigations, based on what we have found so far, you think we need to order? I'll give you, again, a couple of minutes. Perfect. That's perfect. So as we have previously mentioned during our surgical webinars, it's probably good to try to divide investigations into the bedside investigations, then blood, then radiology, and then further tests. So indeed, we're going to do some blood tests for the patient. The patient's presenting with a chest pain, so we're going to do the ECG as well. The most important test in here would be the endoscopy, which I'm going to talk you through. And there are also another tests which you have rightly identified. So esophageal manometry, that's a very important test as well. And these are all very, very good answers. So I'm going to tell you what we're going to do for John in just a second. All right. So in this particular case, we're going to start with the blood tests, and rightly so, you have identified that apart from our baseline surgical bloods, which I hope everyone is aware of, so those would be full blood count, LFTs, USANEs, CRP, clotting, and group and safe. We might want to add amylase. We might want to add troponin, because the patient is presenting with chest pain, and a bone profile, just to see for any electrolyte disturbances as the patient has been vomiting. So we're going to do the ECG as a bedside test. We're going to do the bloods. And then the very important tests are specific for this presentation. If we're thinking that the patient might have gastrointestinal reflux disease. So as I did say previously, our differentials would be gastrointestinal reflux disease, upper GI cancer, so most likely stomach or esophagus, or esophageal dysmotility. So important tests in here would be esophageal manometry. So you can see it in here on the bottom left side of the screen. This is a patient who's undergoing an esophageal manometry. So the pH monitoring catheter is inserted via the nose into the esophagus, and it monitors the pH continuously for 24 hours a day. And there is a monitoring device which records the pH in the esophagus. And if the pH is less than 4, majority of the time, then that is diagnostic of gastrointestinal reflux disease. This test may or may not be done because most of the time, if we don't suspect any red flag symptoms, then we can diagnose gastrointestinal reflux disease based on the clinical picture only, and we might not need to do the manometry testing. However, if we are worried about red flag symptoms, we might think that the patient might have cancer, or the patient has had symptoms for a very long time and they don't seem to be getting better, then the most important test is going to be the endoscopy. So looking on at the right bottom hand corner, which is supposed to show a patient undergoing endoscopy. So the endoscope is put through patient's mouth. The light sedation and anesthetic might be used, like a topical anesthetic, to make it more pleasant for the patient. And then the scope goes down to visualize the stomach, the esophagus, and a part of duodenum. And this test is the most useful and the most suitable in a patient who we suspect might have an upper GI malignancy. It's also very useful in visualizing potential complications of the gastroesophageal reflux disease, such as strictures or esophagitis. And then other tests that we do have in here. So at the top in the center, another investigation that we could do is esophageal monometry. So this is a test used to exclude esophageal dysmotility disorder. So essentially it looks, there's a catheter put inside the esophagus, and it looks at the pressure inside the esophagus. So to see if the normal esophageal contraction and relaxation sequence is intact. And again, if the history does not sound typical of gastrointestinal reflux disease alone, then we can do the manometry studies to try and exclude the dysmotility disorder. Another test that you might think about is at the just at the top in here in the right-hand corner. You might think about doing a CT of the chest, abdomen, and pelvis, but that will only be suitable in patients in whom, first of all, you do suspect a malignancy, to either look for distant metastases or if the patient is not suitable for endoscopy. Okay, but moving on, I would just briefly touch on the relevant anatomy. So if you can have a quick look at the picture on the right-hand side, is just a brief outline of the upper GI tract. So it goes from the oral cavity, and then you have your pharynx, and then the esophagus, which is then connected to the stomach. And then the important part in here is the gastroesophageal junction, which I'm going to talk about in a second. Then you have your stomach. Then this is connected to a duodenum. Okay. And then the border between the upper gastrointestinal tract and the lower intestinal tract is in here at the third part of the duodenum. So just in here at the bottom, and it's along the suspensory ligament of Treitz. So just to orientate yourself in here, this is the duodenum, this is the diaphragm, this is the aorta at the back, and the esophagus would be here at the front. Okay, so the third part of the duodenum, which is connected to the suspensory ligament, demarcates the transition between the upper gastrointestinal system and the lower gastrointestinal system. And then if you could focus for a second on the top left-hand corner, this is going to be relevant to the pathology we're going to discuss in a second, the gastroesophageal reflux disease. So if you look in here, you have the esophagus, and that is joined to the stomach at the gastroesophageal junction. And this is surrounded, or it contains, that lower esophageal sphincter. And for the patient to, for the gastric acids to stay in the stomach and not leak into the esophagus, this has to be patent and open when the food is coming through, and then stay closed when the food is being digested in the stomach and mixed with the stomach acid. All right. So, as I did say, apart from our initial workup, the blood tests, the ECG, the bedside investigations, as a junior doctor, you have to be aware of when to refer a patient for urgent upper GI endoscopy. So this is very important. This is why you have to make sure you ask all the right questions, which I briefly told you about before. And then you have to then decide if it's going to be an urgent or non-urgent upper GI endoscopy, or whether the patient needs upper GI endoscopy at all. So so the Institute of Care Excellence in the UK suggests that an upper GI endoscopy on a 2-week wait pathway should be requested for a patient who presents with dysphagia, so this new difficulty on swallowing, or in a patient who's aged over 55 or over and does have weight loss, and does have any of the following. So there have to be 3 components. So it's either just dysphagia, or the patient is age 55 or over, has weight loss, and has any of the following: the upper abdominal pain, reflux, or dyspepsia. The guidelines also suggest that you should consider non-urgent upper GI endoscopy in patients who present with hematemesis, so they're bringing up blood, in patients who are aged 55 and over, who also do have any of the following. So their dyspepsia, so indigestion, is resistant to treatment, or they have upper abdominal pain with low hemoglobin, or they have nausea and vomiting, which is associated with any of weight loss, reflux, dyspepsia, and upper abdominal pain. So you can see why it's really important to ask about all of those symptoms, because it lets you decide if the patient needs an urgent referral, non-urgent referral, or does not need an endoscopy at all. So these are very important questions, because essentially knowing about patient symptoms will let you decide if this is something that we have to worry about imminently. Is it an underlying cancer, or is it a benign gastric reflux disease? All right, so based on what you have learned so far, are you going to refer John for endoscopy? And if so, are you going to refer him on a 2-week wait pathway? Are you going to refer him on a non-urgent pathway, or you think that at the moment there's no need to refer him for upper GI endoscopy? So again, I'll give you a few minutes to answer. So far, a majority of you have said that, yes, you'd like to refer John for endoscopy, but you'd like to request on a non-urgent pathway. Let's just give you a bit more time to cast your votes. All right, so majority of you did say that you'd like to refer John for non-urgent upper GI endoscopy. And this is indeed what should happen. So just going back, the urgent referral would be necessary if John had dysphagia. He doesn't have dysphagia. He is aged 55 years and over, but he doesn't have any weight loss. So he doesn't have those 3 components that would warrant an urgent referral. But highlighted in here in orange are John's symptoms. So he is age 55 years and over, and he does have nausea and vomiting, and he also does have reflux, dyspepsia, and upper abdominal pain. So he does have symptoms that do warrant non-urgent referral for upper GI endoscopy. Right? So we have sent John for upper GI endoscopy on a non-urgent pathway. And we have also performed some bloods. So his blood tests came back as absolutely normal. And on endoscopy, this is what we're seeing. So there are 3 different pictures from John's endoscopy. If you have a brief look, I'll give you a few more seconds. And if you could give me a diagnosis, what you think could be happening. So just to help you orientate yourselves, this is the view from the inside of the gastroesophageal junction, which is around here. This again is a picture of the gastroesophageal junction, and this is the view of John's stomach. So what do you think? What do you think the diagnosis is? I think we're going to go to next. Perfect. So far you have said that it could be cancer or it could be Barrett's esophagus, stomach cancer, okay, ulcer. Any other suggestions? All right. So let me just show it to you again. Well done to those who said that it's Barrett's esophagus. So this view in here and in here to a lesser extent is a classical picture of Barrett's esophagus. And I'm going to explain what that means in a second. But if you just look in here, there is this white mucosa and then this red mucosa around here, which is abnormal. And then same in here, you can see the streaks of this red velvety appearance, which is abnormal. And in here on the right hand side, this is just a view of a normal stomach mucosa. So there are actually the tortuous lines in here called rugae are normal parts of the stomach, and they stretch when the stomach is full. So this is a normal view of an empty stomach. So there are no tumors, no signs of cancer here. And same in here, this is Barrett's esophagus. And this in here is just, this is not a tumor. This is a normal appearance of at least on the macroscopical level, this is not cancer. This is just gastroduodenal, esophageal gastric junction. All right, perfect. So we have diagnosed John with Barrett's esophagus, which I will get to next. But he also does have gastroesophageal reflux disease based on his symptoms. So the gastroesophageal reflux disease is caused by gastric acid and gastric contents leaking out to the esophagus. And that results in pain and damage of the mucosa in the esophagus, because essentially the mucosa in the esophagus is not well suited for the acidic environment. This is why in normal people, the gastroesophageal sphincter should be tight to prevent the acid reflux, because the stomach lining is way better suited to deal with this acidic environment. So in gastroesophageal reflux disease, the acid leaks into the esophagus, and that causes symptoms and damage of the lining of the esophagus. And this is due to a dysfunction of the lower esophageal sphincter. And the risk factors are increasing age. So John is 68. He's at higher risk at developing GORD compared to his younger counterparts. Obesity, male gender, high alcohol intake, smoking, caffeine, and spicy foods. And some of the symptoms, or the classical symptom, is going to be the burning retrosternal sensation, sometimes described as chest pain. So this is why we call it the heartburn, because it's the chest pain around the heart region, which also feels like burning. Patients might complain of increased belching, odonophagia, so pain on swallowing, and chronic nocturnal cough, because the symptoms are worse when the patient is lying down. At night, the acids will travel up to the esophagus, and that is going to irritate the throat, and the patient might cough at night, but this also might happen during the day. All right. And Barrett's esophagus, as you have rightly identified, is usually caused by, is usually seen in patients who do have gastroesophageal reflux disease, And it is a metaplasia of the esophageal epithelial lining. Metaplasia means a transformation of one differentiated, so one mature cell into a different cell. So in this case, you can have a look in here at the bottom right. You can see on the left side of this picture, there is a stratified squamous epithelium, which is a normal epithelium seen in the esophagus. And on the right-hand side, you can see this simple columnar, so like column-like epithelium with glands in here, which is seen in the intestines and in the stomach. So in Barrett's esophagus, this lining of the esophagus, so the stratified squamous epithelium, is transformed to this intestinal lining to be able to deal with this damage, erosion, and an acidic environment better. It is a reversible change. So once the problem is removed, so if we can stop and control the acid reflux, it is a reversible condition. So the Barrett's esophagus can reverse back to normal mucosa. And as I said, it's caused by chronic acid reflux, which damages the lining and then triggers this transformation to a lining that's more resilient in the acidic environment. At the time when people with GORD seek medical attention, 10% of people already have developed Barrett's esophagus. The way we diagnose it is with endoscopy and biopsy, and it's a histological diagnosis. So when you do the endoscopy, you can see this characteristic appearance seen in here and on the previous slide. Then you take biopsies, and if on the biopsy from the esophagus, you can see this simple columnar epithelium with glands, then you have the diagnosis of Barrett's esophagus. Symptoms are very similar to gastroesophageal reflux disease, and those, as I mentioned, usually overlap. The risk factors are being Caucasian, being a male, being older than 50, smoking, obesity, and having a hiatus hernia. And it's there is a risk that Barrett's esophagus might progress to cancer, and this is why we have to keep an eye on the patients with Barrett's esophagus by doing a regular checks with upper GI endoscopy. And if at any point during the surveillance a high-grade dysplasia is found, that means that there is a higher risk of progression to cancer. So we'd have to intensify the endoscopic surveillance, and sometimes parts of the lining might have to be resected. All right. So I kind of gave it away a little bit, but if John does have, if he does have Barrett's esophagus, then what are we going to do for him? What do you think? So I did mention the surveillance endoscopy, but are there any medications that we can give to him? Are there any, is there any other advice that we can give to him, or anything else that you can think about? And again, I'll just give you a minute or so. Perfect. All right. Thank you very much for answering. And let me just try and summarize it. So the management for John would be starting from simple measures, a lifestyle advice. So as you rightly did say, we're going to advise John to avoid alcohol as much as possible, or at least try to reduce it. Try to avoid any triggers, so coffee or fatty foods. we'd strongly encourage him to stop smoking, and we can refer him to a smoking cessation service if necessary. For patients with gastroesophageal reflux disease, we're going to give them a proton pump inhibitor medication. So, for example, omeprazole, which is most likely going to be required lifelong. Later on, if this lifestyle advice and the proton pump inhibitor is not helping after a couple of weeks or a couple of months, then the patient can consider surgery. So the options that are available are Nissen fundoplication, which you can see in here on the top right. So you have a loose lower esophageal sphincter, then you pull up the fundus of the stomach, and then you wrap it around to tighten it, essentially. And the newer techniques include radiofrequency. So endoscopically, you deliver radiofrequency to thicken the sphincter, or you can surgically insert some magnetic beads. So it's called a Lynx method. And those are titanium beads that go around the esophageal sphincter and strengthen it as well. In patients who have Barrett's esophagus, so in John's case, they will need regular endoscopy and biopsies, plus minus a resection. So again, depending on what is found on the endoscopy and on the biopsies, you might have to intensify the surveillance. In patients with Barrett's esophagus, they need high-dose proton pump inhibitor, and lifestyle advice is the same as for GORD. All right. So we have given all this advice to John, and he was on high-dose proton pump inhibitors, and we have followed him up with routine endoscopic surveillance, and his symptoms were initially well controlled. However, 5 years later, he now presents to you again. He does have ongoing acid reflux. He's developed this new difficulty in swallowing for the last 7 days. He complains of epigastric pain, and on further questioning, he tells you he's lost about 10 kilograms over the last 3 months. And in general, he feels weak and has lost his appetite. On the right-hand side, you can see the latest endoscopy that John had performed. So this is the view of his esophagus. And what do you think the diagnosis is now? Okay, so far, majority of people said adenocarcinoma of the esophagus, with 1 vote in favor of squamous cell, 1 more vote, squamous cell esophageal cancer. Okay, so you've rightly identified that now it's not simply gastroesophageal reflux disease or Barrett's. There's something sinister going on. So not only does John have red flag symptoms, but he also does have a visible tumor on his endoscopy. So let me just go back. So you can see that this in here, all of this is a tumor. And it's near where the esophagus joins with the stomach, so the lower third. All right. So very well done. He has developed esophageal cancer. And you rightly have answered that it is more likely to be an adenocarcinoma. So esophageal cancers, there are 2 main types that we see. The squamous cell carcinoma usually affects the upper and middle thirds of the esophagus. And the risk factors are mainly smoking, alcohol excess, achalasia, low vitamin A, and low iron. And then adenocarcinoma is usually seen in the lower third of the esophagus. So you have seen it on the previous slide, and you can see it in here as well. So in this case, you can see the progression. So you can see the Barrett's, the classical appearance of Barrett's, and you can see the adenocarcinoma on top of that. So the adenocarcinoma happens in the lower third of the esophagus, and there's this progression. So there's a normal esophagus, and then that can progress to a Barrett's esophagus, which is a metaplasia. So I did say is this reversible change, and that can then progress to a neoplasia and a malignant change, so the adenocarcinoma. And the risk factors for that are chronic gastroesophageal reflux disease, obesity, high fat intake. And the management of those patients, for squamous cell carcinoma, we don't operate because it's very difficult to perform surgical excision of the tumors around the epithelium, the middle of the esophagus. So those patients are given chemoradiotherapy. For adenocarcinoma, the patients will get chemoradiotherapy followed by a resection of the lesion. Unfortunately, most cases at the time of presentation are too advanced for either surgical or even curative chemoradiotherapy. So the majority of the cases require palliation with either stents to alleviate the obstruction, nutritional support, or sometimes surgeries that will just shrink the tumor but not necessarily be curative. And the 5-year survival is between 5 to 10%. The surgical options include Ivor-Lewis esophagectomy. So just briefly, you have this right thoracotomy, laparotomy, and then you excise this part of the esophagus, you excise top of the stomach and all the lymph nodes, and then you pull it up and create a conduit. Maquillon esophagectomy is another approach to treatment of adenocarcinomas, but now you're going to have an incision on the right side of the chest, you're going to have a laparotomy, and you also are going to have a neck incision. But essentially the outcome is very similar to create this conduit by excising esophagus, top of the stomach, and the tumor and the surrounding lymph nodes. All right, just to briefly touch on the gastric cancer, it's a relevant, it's an important differential because the symptoms of gastric and esophageal cancer tend to overlap. So just briefly, the gastric cancers, over 90% of them are adenocarcinomas. So you can see in here at the top, you can see some pictures of the stomach cancer. So there's one in here, and then in here, this appearance of a very widespread stomach cancer. The risk factors include being male, having Helicobacter pylori infection, increasing age, family history, pernicious anemia, and the symptoms very similar to the esophageal cancer, very similar to GORD. So dyspepsia, dysphagia, early satiety, vomiting, melena, and anorexia. And the referral criteria, the NICE guidelines for referral criteria are the same. So the symptoms are the same for esophageal and gastric cancer. So you can later have a look again when the symptoms would warrant a 2-week referral or a non-urgent referral, but essentially those symptoms are very similar for gastric and esophageal cancer. Signs in patients with gastric cancer might include a palpable mass in epigastrium and a Troisier sign, which, as I did mention before, is this palpable lymph node in the left supraclavicular fossa. So that is suggestive of malignant cancer in the abdomen and most likely gastric. And again, the survival of those patients, unfortunately, is very poor. And at the time of presentation, the disease tends to be quite widespread and non-curable. But the options available is perioperative chemo. So patients usually get 3 rounds of chemo before, 3 rounds of chemo after. If it's a proximal cancer, we do a total gastrectomy. And if it's a distal cancer, we do a subtotal gastrectomy. And just to show you how it looks, total gastrectomy in this case. So if a patient has a proximal tumor, we're going to take out the entirety of the stomach, and then you're going to do this end-to-end anastomosis between the esophagus and a small bowel, and end-to-side anastomosis of the far end of the duodenum and the more distal part of the small bowel, and that gives the best functional outcomes. So it's called the Roux-en-Y reconstruction. All right, so just to summarize, gastroesophageal reflux disease most commonly presents with retrosternal chest pain, which is burning in nature, but it's really important to remember non-gastrointestinal differentials. You should always ask about red flag symptoms, because depending on what symptoms the patient might have, you might have to consider urgent or non-urgent endoscopy to exclude cancer or to look for potential complications of gastroesophageal reflux disease. If the patient is found to have Barrett's esophagus, they need regular surveillance endoscopy, because there's a high risk of progression to adenocarcinoma of the esophagus. Unfortunately, the gastric and esophageal cancers still have poor prognosis, but there are surgical and adjunctive treatments available. And if your patient does have symptoms, the red flag symptoms that warrant a referral, you have to make sure you do a 2-week wait referral for the patient. So just a quick reminder that you can sign up to the webinars if you haven't done so far on mindthebleep.com/webinars. And then there are some articles. So we have already uploaded some of the new articles on the topics that we have covered previously. So apart from accessing the videos, you can also now read the notes, which are available at mindthebleep.com/surgery. All right, so if you have any questions, please post them here. And let me just go out quickly to post the feedback link in the meantime. All right, so you can access the feedback link on the Facebook page already. So please do fill in the feedback form, because it's very important for us, because as you can see, we do try to adjust our sessions based on the feedback they give us. And we find it very, very useful. And we try to tailor the content of the session to your needs. So if you can think of anything at all that will be beneficial for you, we'll be happy to hear from you. And also, if you do fill in the feedback form, you'll get the access to the video and the written materials, and you also get a certificate for your portfolio, which is really important, because the sooner you start building your surgical portfolio, the better and easier it's going to be for you later on. So do you have any questions? Oh, the feedback link is not working. That is very important. Okay, just give me 1 second. That is awful. Can you try scanning the QR code? Well, actually, I think I know what I've done wrong. Just give me 1 second. Okay, if you can try now. This is the new link. Okay, you can keep posting the questions. I'll go back to them in a second. Let's just see if this is working. Oh dear, I'm very sorry that I can't access the feedback link. I can see. You can keep posting the questions. Just give me 1 second to sort this out. Apologies to everyone. Okay. Okay, the feedback link, which does work, should now be up. Yeah, apologies everyone. Please use the last one I did send. I'll give you a couple of minutes to finish the feedback, and then I'll go through any of the questions that you might have. But please fill in the feedback form, because it's really important for you, and it's really important for us. And we do value it and try to change according to your suggestions. So I'll give you just a minute. Perfect. Let me see if there are any questions here. So there are two questions. The feedback link should be working, I promise, because I checked it myself. So there are two questions in the chat. The first one is how often you do the endoscopic surveillance for the patient who has Barrett's esophagus. So I didn't include that in the session because I thought that might be going into too much details. But essentially, depending on the findings, so if there's Barrett's but there is low grade dysplasia, then I think it's something like 6 to 12 months. But let me double check so I'm not lying. But essentially, if somebody has a high-grade dysplasia, then you intensify it to every 3 months, and then so on. But I thought that was outside of the scope of their presentation. But essentially, it's going to be between every 3 months to every 6 months, every 12 months, depending if it's a low-grade or high-grade finding. And if it's adenocarcinoma, then you have to deal with it straight away. If it's a high-grade dysplasia, you might have to resect some of the bits of the esophagus as well. And somebody has asked, well, let me post again. Okay, please see if this one's working, and I can put the QR code as well. Okay, let's try the QR code. So those of you who have an access can access it as well and move my face away. Another question was how you advise the patient, what you tell them before the endoscopy. So you have to warn the patient that it's going to be uncomfortable. It is quite a big scope that goes into patient's mouth, and some patients find it very uncomfortable, especially because it triggers the gag reflex, and it's a fairly uncomfortable examination. But you can advise the patient that they're going to have this numbing spray and they're going to be slightly sedated, so they shouldn't feel it. They shouldn't feel it as much. But some patients find it very difficult, and they find it very, very difficult to tolerate. But I think it's all about managing expectations, and it's really important to tell the patients that it's going to be uncomfortable. We try to do our best to make it as comfortable as possible. But the reason we are doing it is because we're thinking that you might have cancer. So it's really very important that the patients are on board and are aware of that. Okay, perfect. You have hopefully scanned the feedback form. please do. Very helpful. Let me go back to the question. How do you differentiate between hematemesis and hemoptysis? Hematemesis is vomiting up blood, so it's blood in the vomit. Hemoptysis is blood in a sputum. So you kind of have to, sometimes it's very difficult to differentiate, but sometimes it's really obvious. And, you know, you can see the patient vomiting, bringing up gastric contents, and there's a blood in it. And hemoptysis, again, just look at the quality and quantity of the blood and of the fluid that comes in it. And sometimes patient might even describe that they can see the blood whilst they're after they coughed. So that's more likely to be hemoptysis than hematemesis, or they may tell you that I've vomited and then there was blood in it. With the patient, sorry, somebody asked why in this case the complications of the Barrett's were not dealt with. I kind of fast forwarded to make the case more variable for you, but obviously in a patient who's on a surveillance, that we should be able to catch any high-grade dysplasia at a very early stage and hopefully stop it from progression to adenocarcinoma. However, that's not always the case. So actually, some of the patients who are on surveillance can still develop adenocarcinomas, but because they're under surveillance, we're more likely to catch the cancer at a much earlier stage, which means that the prognosis is going to be much better, and we can potentially try to surgically remove it. How do we differentiate absolute red flags versus warning symptoms? I think at this stage, the important things would be to bear the red flags in mind, include them in your history taking, and then discuss it with a senior to be able to differentiate for sure if this is a warning sign or if this is a red flag. So I think it's really important to be aware of them and to be able to elicit that in the history. But at this stage, I think you might have to rely on the senior support to be able to be 100% certain if you're managing the patient well. And what to look for in the routine endoscopy regarding Barrett's esophagus and what interval should they be done? So I think I've kind of covered the intervals, and then what we're looking for at during the endoscopy is we look at the appearance, so we can see this velvety change of the mucosa. We're looking for any obvious macroscopic tumors, but also the patients will have biopsies taken. So during the routine surveillance, we take the biopsies and then we look at them under the microscope to see if there are any changes. They're not just Barrett's, but they are cancer. So there's going to be a specific appearance under the microscope that will tell us if this is a very small cancer or is it still Barrett's. I will sort out the certificate issues in just a second. If you have any problems, please do get in touch with us and we'll send the certificates to all those people who couldn't access. But in the meantime, are there any other questions? Let me go back, or you can post them in the Facebook chat. If not, please get in touch with us at webinars@mindableep.com or via our Facebook page if you have any questions or any issues at all. The next session is going to be on peptic ulcers and upper GI bleeds, and I hope you'll all join us for the talk next Monday, the same time. So for now, thank you very much, everyone. Please make sure you fill in the feedback forms, and if you have any issues, just get in touch with us.